October 17th, I'm Shane Christian, filming on heart and blood vessels.
Hi, well, first I would wash my hands, okay, and then I'd approach the patient. Hi, my name is Brian Bacallion. I'm a Nursing Liberty student, and I'm here to assess you for your heart and vessels. May I have you state your name and date of birth?
Josh Lilly, 5/16/93.
Okay, that's great. Well, thank you so much for unbuttoning yourself so quickly. Right now I'm just going to go ahead and get started on just explaining that blood pressure will be done first on the patient while lying down, sitting, and standing up. A difference of measurement of 20 will suggest orthostatic hypertension in the patient. Assessed in vitals, the patient was not indicative of orthostatic hypertension. All measurements fell in range. Next, I would inspect across the precordium, the aortic area, pulmonic area, Erb's point, the mitral area as well. And inspecting the patient for JVD, I would have the patient deprominate his chin, tilt. This would promenade the carotid arteries. I haven't noticed any obvious distension. Bilaterally assessed, no obvious pulsation. And across the precordium, I did not notice any obvious pulsations as well. Moving on to palpation. I palpated along the aortic area. Okay. The pulmonic area. Erb's point and tricuspid can be felt at the same time. And the mitral area. Okay. I did not feel for any heaves, thrusts, thrills at the moment, and I go ahead along with auscultating the patient. And I must note that the mitral area, apical pulsation was felt and at a normal rhythm and rate, moderately palpated, lightly palpating, done across the precordium at 1 centimeter. Moving on to auscultating the patient. Second intercostal right sternal border of the aortic valve. Left sternal border, the pulmonic valve. Third intercostal space, tricuspid valve. Third intercostal space, Erb's point. Okay, felt. Tricuspid valve at the fourth intercostal. Okay. And the fifth intercostal space at the midclavicular line. This is the mitral valve, where PMI is located at 1 centimeter or less. Okay. Through this assessment of auscultation, I've concluded that I have not heard any loud heaves, lifts, thrusts, murmurs, and thrills. The patient, and I would go ahead and assess the patient for their blood vessels next and arteries. I'll start ahead first with the temporal arteries. I palpate one at a time. I'm comparing them bilaterally. Next to carotid arteries. Okay. There's no venous humming. I would auscultate all of these arteries as well. Next, I'd assess the patient's brachial arteries bilaterally. The radial arteries. The femoral arteries would be palpated as well, not in this assessment. Next, the popliteal arteries. It's right behind the knee. Bilaterally assessed. Okay. And next, I would assess the medial malleolus. And last, the pedal pulse. This is assessed on the arch of the foot. Okay, pulsation was not picked up during pedal pulse, the palpation. We would go ahead and use the Doppler instrument, and by applying the lubricant first on the area, and then this would be used as a conductor to pick up to any kind of turbulence and flow. And through the entire assessment of palpating the arteries, I've felt normal rhythm. They were both symmetric on both sides, important. They were strong, and I did not hear any. I did not feel for abnormal distension of the arteries, and of course I would be auscultating these arteries as well to assess the patient. Next, I'll have the patient lie down. I'll have you slightly flex your knee, and I want you to dorsiflex your foot. Okay? I want you to do it on the left side as well. Have you felt any pain in your calf at all?
No, sir.
Okay. If the patient had felt calf pain, this would be indicative for defining Homan sign of having a venous thrombosis. During my auscultation assessment of the heart, I heard S1, S2 sounds equally at Erb's point, and the S1 was predominant in the aortic area, while S2 was predominant in the pulmonic area, pulmonic valve, and that would conclude the assessment for blood vessels in the heart.